Good afternoon and welcome back to our next session, Supporting Families Growing Together. My name is Becca Bolas and I'll be moderating today's session. A couple of reminders before I introduce our speakers. The first is that we are offering conference captioning services. Within each session, you will automatically be provided with captioning, and that appears beneath the video stream. You can click the link to access it in a separate window if you prefer. And if you don't need the service, you can push the pause stop button to stop the stream. The second brief announcement is just a reminder to please be sure to complete the session evaluation. We're not at the end of the conference yet. It's just 4 short questions and your feedback is very helpful to us. The link to access it is right in the virtual room where you are right now, and I'll also add a link to the chat. So with that, I'm excited to introduce our speakers for this next session, Annette Burns from Penn Bay Pediatrics and Steve Giovanni from MMC Outpatient Clinics.
Hello, everybody, and welcome. We're super excited to present our work around the early childhood support specialist. And most excitingly, we have one of our early childhood support specialists doing the presentation. My name's Steve. I'm a medical director here at the teaching clinics at Maine Med. And then I do a lot of work for the Maine Health System around adversity and resiliency with a focus also on social determinants of health. And then I'll have Annette introduce herself.
Hi, I am Annette Burns. I am an early childhood support specialist at Penn Bay Medical Center here in the pediatric offices. And I do have to add that we do not have anything to disclose with regard to commercial relationships. It's nice to be here today.
All right, so I'm going to give a little bit of an introduction, and then the majority of the time will be Annette. This idea came to us a few years ago, in that basically we just saw a gap in the health system, and that that families who were struggling, there just wasn't a structure in place in pediatric offices really to help support them. And in addition, there's an incredible amount of research coming out about early childhood development and the way the brain connections are made over the first years of life, and where that is when your brain growth happens and when we should be building brains that will support health, development, education, and relationships for the rest of the individual's life. In general, I would say society and medical care underfunds care for this group. So this is a way of bringing some extra funding in and seeing what we could accomplish. There was no real low barrier, just-in-time case management support that are built into most pediatric teams, but it's something we see on a daily basis, and I would say a lot of teams struggle with. And then, families need support around positive, developmentally supportive parenting and these social determinant of health barriers, and that's what we were really trying to address. Next slide. We were super excited to get to work with the John T. Gorman Foundation. They've been incredible partners, not just in providing the monetary support, but also providing ongoing consultation and assistance and idea generation, which I really haven't gotten in almost any other granting agency that I've worked with. So it's just been fantastic. As I said, what we're trying to do is resilience building, very low barrier, so it doesn't, there's no qualifications to get Annette support. If someone needs help, we support. It also focuses on parent education, really taking that 2-generation approach, so that if we can keep the parent healthy and doing well, we can help support the child's health, and vice versa. If you help the child thrive, the parent can thrive. There's 2 sites, one urban here in Portland, with by 30 different languages spoken at the clinic here, and then a more rural site up in Rockport. And I would say it's interesting to watch those differences, but many of the families at both sites have a lot of struggles and things that we should be able to help with. We did a 3-tier system so that the early childhood support specialist is not overwhelmed with trying to help everybody, and trying to really set people into which families really need significant ongoing support, but then to hopefully move people out of the tiers so we can continue to bring in new families to support. Next slide. So tier one mostly is a quick introduction, usually at one of the first visits at the pediatric office, and that may just introduce yourself right at the well child visit. This is my role. This is what I do. Here's my card. Is how you contact me. If time permits, maybe doing a little bit of developmental teaching, but pretty brief in that situation. But then using that visit and referrals from the pediatricians or other providers to identify patients who might be into tier two or tier three, who have, say, significant social determinants of health or other things that might put the child at risk for developmental delays or school issues, such as adversity, medical diagnoses, such as neonatal abstinence syndrome, prematurity. We have a lot of children here with sickle cell, or if, say, DHS had been involved. Tier three usually is looking at families are having significant struggles or disruption, high adversity levels, potentially related to, say, substance abuse, mental health issues that have parents, extreme poverty, or intimate partner violence, those types of things, where we're expecting the ECSS to really be working hand in hand. And for all these tiers, also, working hand in hand with the community and the providers. And that will kind of highlight that in a much more hopefully succinct and better overview. Next slide.
Well, thanks, Steve. That was great. And I feel very honored that I could be here today to share a role that I have personally been doing for 1 year now. And it is a role that has not happened before within the well child or the pediatric sites. And I am very pleased with the work that I've been able to accomplish this past year. And again, honored to be here to share it with you today. Basically, Steve gave you the overview, and my job here is to connect with families that have children ages birth to 3, and to start building relationships right away and meet as many babies as I can, which is a wonderful perk to the position. Basically, keeping in mind that it's about where they're at. It can't be, I can't go in making with any assumptions. They're there with their new babies, which we all know can be very overwhelming anyway. But just being there and listening, commiserating, celebrating, all of those things that brings a family to their first few well child visits here at the pediatric offices. We can start a conversation that I start very open-ended with every single family, and is there anything I can do to help you? We want to be a parental resource, and we want to be developmentally supporting those parents and keeping communication open and developing relationships that if a situation should arise or there are substantial problems or resources that need to be connected with this family, we're doing it in a very appropriate manner. So I've previously, my personal histories and a background of early childhood education, and I have worked the gamut from Head Start to the elite private care sectors. So, but I always said, the children were the same, regardless of socioeconomic backgrounds, what kind of supports families were receiving. So my role is really instrumental at meeting and understanding a place where a family is at. If there are needs to connect to resources, we want to be bridging those gaps. Sometimes here in the mid-coast, in the rural section, it's harder for some, limited internet access, transportation issues. So just getting to a well child visit is often just a goal with some of these families. Some of I call them my top helpful agencies here in the mid-coast, are getting in there and having collaborations with DHHS, WIC offices, the Hospitality House of the Knox County Homeless Coalition. Penquist is a large community support now in Knox County. The Maine Housing Authority, because we are dealing with a lot of housing issues all over the state, but we're really struggling here in the Mid-Coast that I can see. Our Area Interreach Outreach Program, or AIO, is our food pantry. They are able to help with a variety of resources for families, and child development services has been a big piece of taking the referrals from a well child visit if needed and making sure that those connections happen with families. I had mentioned earlier that we can't really go in there with any kind of preconceived notions of what this family has been through or what they're going through, or how, you just really have to be there to, at first, introduce myself, what this role is hoping to achieve with all families that come into the practice. And then if there are some issues or problems or struggles with families, to be able to listen, to be able to provide pertinent resources. I tried not to focus on what may or may not be available at that time. So it's important for me to keep a pulse on valuable community resources that will be there to help families, instead of maybe miscommunicating some services that are no longer relevant in this area. So to listen, to follow up, but ultimately to provide some netting, some assistance to alleviate stressors that may be happening in a parent's life, which ultimately could help establish a much better bonding relationship with their young children. The immediacy I spoke briefly about prior is, many times if there is a circumstance or an issue that is very pressing, we are seeing some homelessness. We do have some families that are housed right now in hotel rooms that may not have access to cooking supplies. And we do work with the Good Shepherd Food Bank. We have some food bags, which they have recently offered, the no-cook bags, where you can use the foods without having to have cooking products. But some of the work connections that we do are coming up with resources to car seats, to and crib sheets. I have storage unit fees. Each story is unique and different. When we are working with families, just filling out an income-based housing application, we had heard earlier that can be quite intense for some. And I'm able to work with families to walk them through those initial applications, and maybe the next 15 to 20 they can fill out on their own once we get that process started. I'm available to research through medical supply companies looking for baby scales for medically necessary kids who are struggling to come in once a week for weekly weight checks, connect families to public health nursing, making sure that those resources that I'm connecting them to are going to be helpful and just in time. I had mentioned earlier, one of my most important goals is to keep up to date with the patients that are coming in, especially our younger patients that I'm connecting to helpful resources, to making sure that they get to their well child visits, because we all know that's when they get their immunizations, that we're doing our social determinant of health assessments, that we're looking at ACEs scores. All of these things help culminate who and when I work with families, and based on their own sharing as well. So we are grant funded, and some of the immediate and wonderful ways I can help are to be able to offer gas card assistance, scheduling with Midcoast Connectors, our main care transportation system, and the self-drive reimbursement programs that they offer, which a lot of families before I started didn't even know existed. I don't think Main Care has a site that comes up and says, hey, we'll reimburse your mileage if you have Main Care. It's not something that's advertised, but a resource that is very helpful just the same, especially when the gas prices were up and around $5 this summer. So that's one big piece, making sure that we get these families here, scheduling those well child visits to fit their schedules, and assisting them if transportation costs are needed. The grant has offered some funding so that I have established a diaper pantry here in the practice at Penn Bay Pediatrics. Emergency, instead of just a diaper if needed at a well child visit, we're sending mom home with the whole package of diapers. And if anybody has had to purchase diapers recently, that could be the difference between putting enough gas in the gas tank, buying diapers, or if medicines are needed. These are just certain items that are very costly to families who may be struggling. They come into a well child visit. Getting to know me, I become a resource, kind of a safe place for them to say, I really could use some diapers. I have been using my diaper pantry, but I've run out. I don't think I'm going to make it until next week. And it's just one of the feel-good ways that we are able, with the grant funds, to be able to assist them with packages of diapers and wipes. Our vendors have graciously provide our practice with formula. I've worked through the EIO food pantry when we were in a formula crisis, and I was able to liaison with them for some of those specialty formulas that families were really struggling, like Nutramigen, Progestamil, to find these formulas. And it became, I was the investigative, I felt like the underground formula ECSS person here in Rockport, but to really keep my nose to the ground, where some families with new babies who are needing these formulas were so overwhelmed with finding them, it became kind of my superhero cape kind of job for me. And every time we succeeded, we gave ourselves a pat on the back for finding that for families. I can be reached very, very easily. I am equipped remotely with being able to work remotely, which means I can go into the community. I can go, if there's internet at families' homes, I'm allowed to home visit, which helps me establish online resources, especially if you're applying for SNAP benefits. We all know that it can be a lengthy call on DHHS or on the Main Care sites to have to call in. I'm able to do parent coaching using Zoom. I can go on home visits, and I have a cell phone where now most young parents, I would say probably 75% of the communication with the families that I've established a relationship with are going to text me. That is definitely the modern means of communicating. I'm hard pressed to think that many people answer their phone much anymore. So it's a unique way for me to get in touch ahead of well child visits, send out a text and say, hey, I noticed you have an appointment coming up in a few days. Is there anything that you need from me? Is there any help you need getting here? Let's put a plan in place so that I look forward to seeing you and your child at your well child visit. Plus, I'm right here at the office as much as I possibly can be. Of course, that's how I continue to keep meeting new families and make myself available to the families as they come in. So remaining remote and flexible is a very unique part of this job. So I'm not considered technically case management. Again, we're trying to work with those social determinants of health and see if we can become an immediate resource to try to combat some of these struggles within families with young children. Of course, the pediatricians here say, well, I need somebody with my 5-year-old. Well, that would be the ultimate goal, is that when we look at if how we're improving from 0 to 3, wouldn't it be wonderful if we could extend those age groups to get some of this ECSS work to work throughout the whole pediatric practice. But ultimately, it's to meet these families where they're at. I do some time here. I use community resources a lot. I oftentimes will meet families at the library where we can have internet access. I meet them at local community playgrounds so I can show interaction skills, how to play at a playground with your child. I'm able to interact better with the child and the family there, and showing that the community, just actually alerting families to the resources in the community. We have many wonderful resources here that many might not even know about. So I had mentioned that I just had my year anniversary in this. I'm very happy with how things have been going. Right now, the grant will be going through an evaluation process. We'll be looking at what we've done so far. Portland was ahead of Penn Bay by 1 year, so we've added this rural scene, and it is, as much as I communicate with the Portland ECSS, we're very different in the needs of what our families are requiring. So far, we have 80 tier 1, which we had mentioned sometimes is just an introduction to ECSS services. 40 tier 2 families, which means I'm usually connecting with them 2 to 3 times a month, seeing if the resource worked for them, they are connected, are they receiving the resource, and are there any follow-ups that we need to do. And then I have about 21 tier 3 families, which they are essentially, we're working with some homeless families. There are families that have substance abuse, and for looking at or they're couch surfing, but looking at some significant social determinants, or they are in working with foster families and DHHS guardians. We have identified that 74% with the social determinant of health. We've had certainly some of our tier 2 and tier 3 families had limited access to resources and to transportation in particular. That's what we're here to help with, the connection to SNAP, to WIC, to main care if that hasn't been set up yet, LIHEAP, state income-based housing, and where some of the food pantry resources would be, and to get children to their well child visits. Right now, as passionate as I was with my CDS project, I am advocating and trying so hard to find pediatric dental services in the Mid-Coast area. So these are just some of those common parental goals, always underlined with some parent educationing, or questions and answers around development. I feel like the many years in early childhood education have served me well in this piece. So we have about 61 patients in the tier 2, and we have documented progress, which is a wonderful feeling. I want to wrap this up. This is just a brief little summary of what the work we've been doing with the CDS and with our medical model. And when they put in when the teams put in the referrals for CDS services, oftentimes that bridge it collapses with lack of family engagement. Once the referral's made, CDS can't reach that family, and it could be because their voicemail box is full, or they've run out of minutes. So I'm able to go back, reconnect with that family and say, hey, that referral was made. Have you talked to CDS yet? And be able to guide that family back and make those connections to CDS. And again, that's kind of wrapping it up. I'm very grateful to be here, and that's a brief overview of what some of the things that I do. We wanted to leave some time to have some questions and answers at the end, but I thank you for allowing me to come and talk a little bit about the ECSS role.
Hey, thank you so much. And that one I want to highlight on that CDS slide that the connection rate prior was about 20 to 30%. So these are children at risk for developmental delays and issues. And with Annette's work, that number is up to 80%. And that the impact of that to me is just
Yes, that one, that slide.
so thank you. The other word we like to use a lot for this project is trust, and the trust in the health system, the trust in Annette, and the trust with that practice that we're here to help you. That's the message. And that there's no wrong door. And the answer is yes. We're going to try to do the best thing we can to help you raise your children and help them achieve their developmental, the best development that they can. So thank you, Annette. The work you've done is amazing, and I'm super psyched you're in the position.
Thank you both so much. This was such a great presentation. It was so interesting to learn about this program and the incredible work that you've done in the community. I see one question, but before I get there, I want to remind folks that if you do have a question, please enter it in the Q&A tab. But there's a comment that I just wanted to share with you, just so you're aware. It's from Brittany, and she states that if any agencies have connections or work with low-income families who need car seats for their children, Reddington Fairview General Hospital in Skowhegan offers free convertible car seats and booster seats for income eligible Maine families. So just a good resource for folks to be aware of that is available in that area. So this question came in, Annette, just before you were talking about data, but I'm still going to ask it and maybe kind of build on it a little bit. And the question was around data. Can you talk about the data you collected for this initiative and how you used it? And so you did go through some of the metrics in terms of families that were served and the supports that were needed. Maybe just to elaborate on this question, how did you collect those data, and how are they informing the program now and looking ahead?
Well, we at Maine Health we are integrated into the Epic system. So we have the BI portal reports that I also have my own personal client tracker. When I engage with families, I need to keep some notes and the services or where I'm at with a family and what connections of services I have. So we use smart phrases. We're able to keep track I'm not spending a lot of time on case notes per se, but immediate what the grant has provided versus what the role has provided, using smart phrase technology, and we're able to pull reports up from Epic, and I get those monthly, and I compare them to what I have personally, and then I can see here in the practice, who have I missed? Has somebody kind of slid by me in the scheduling? But we are able to pull significant data to establish the work that we're doing and the connections that we're making.
Yeah, so the EMR was built with smart phrases. So whenever the ECSS is interacting with a parent, they can use that smart phrase, which captures what the SDOH needs are, what the interventions provided, what the parental goals are, things like that. And then we also, each ECSS creates their own kind of registry, which is helps them know, okay, when they're coming in next, did they already get SNAP? Did they have WIC? Did I connect them to CDS? So those types of things. And then the last data, we're partnering with University of Southern Maine to hopefully do some parent interviews, kind of get their impressions of the project, and to bring another kind of data source into the evaluation.
That's great. Thank you. Thank you very much. So I'll give you both, you have about 40 seconds if you have any closing thoughts, and if not, then we'll transition to the next speaker. Do you have any last remarks you want to share with folks?
I just love to see this type of work spread through pediatric and family medicine practices. I think it's just essential, and love to see people advocate for that. I would say it's the one place the kids are all at, so they all don't access WIC, they all don't access Head Start or or main families, but they come to the doctor's offices. So if we can provide this service there, it's a cool way to get in.
I'm enjoying the multifaceted all of the aspects of this role. I've got all my fingers into all the community resources, and I bring them back here to the pediatricians, and they're telling me they're not going to let it go. So.
Oh, that's great. Well, thank you both so much again for sharing about this program. I learned a lot, and I loved that the comments that it also generated in the chat. So thank you very much. And I want to thank everyone who joined us today for this session. We hope you enjoyed the presentation. Just as a reminder, please do complete the session evaluation. Our next session, Youth Navigation Program, Upstream Suicide Prevention and Action, will start after a brief break. So please stay tuned and we'll be right back. Thank you. Good afternoon and welcome back to our next session, Youth Navigation Program, Upstream Suicide Prevention and Action. My name is Becca Bolas and I'll be moderating today's session. Just a couple of reminders before I introduce our speaker. Please note we're offering closed captioning services. Within each session, you are automatically provided with the captioning, and it appears just beneath the video stream. Please be sure to complete the session evaluation. It's right in the session where you are, and I'll also add it to the chat. They'll add the link for you. And with that, I'm excited to introduce our next speaker, Kay Coate from Crisis and Counseling Centers. And with that, I'll turn it over to you, Kay. Thank you.
Hi, good afternoon. My name is Kay Coate, and today we'll be discussing Upstream Suicide Prevention in Action as it relates to the Youth and Family Navigation Program at Crisis and Counseling Centers. I have no conflicts of interest to disclose at this time. During the duration of this presentation, topics related to suicidal ideation, suicide-related behaviors, and self-injurious behaviors within adolescents will be discussed. Our mental health is very important, so if at any moment while viewing this presentation you need to exit, I encourage you to do so. This is a brief overview of our presentation structure for today. All attendees can access the scripted version of this presentation, our agency glossary of terminology, and printouts within the attachment page below this profile. And always, please type any questions in the chat box during the duration of this presentation for a Q&A session at the end. Our friends at the Adolescent Health, Injury, and Suicide Prevention Program at the Maine Center for Disease Control and Prevention sought to establish additional programs that address chronic suicidality in Maine adolescents. By doing so, they sought out funding through the Garrett Lee Smith State Prevention and Early Intervention Program. The GLS program is a grant opportunity offered by the Substance Abuse and Mental Health Services Administration. The funding seeks to address the following outcomes: increase the number of youth-serving organizations that are able to identify and work with youth at risk for suicide. 2, increase the capacity of clinical service providers to assess, manage, and treat youth at risk for suicide. And finally, improve the continuity of care and follow-up of youth identified to be at risk for suicide, including those who have been discharged from emergency departments and inpatient psychiatric units. The Adolescent Health, Injury, and Suicide Prevention Program at Maine CDC created the navigation program to address criteria 3. However, after implementing the navigation program at CNC, we discovered we had successfully addressed all 3 outcomes within 2 years. You can find the navigation program at these following agencies: Crisis and Counseling Centers, Aroostook Mental Health Centers, Community Health and Counseling Services, and the Opportunity Alliance. The navigation program and structures are unique to each agency. Today, I will be discussing how Crisis and Counseling addresses upstream suicide prevention as it relates to youth and family navigation program. Navigators at CNC offer low-barrier therapeutic services to support adolescents and caregivers while assisting them in community reintegration at no cost to our clients. Navigators do so by utilizing comprehensive risk assessments, safety planning, safety measures, counseling on access to lethal means, referrals, and unique one-to-one care to decrease symptoms. CNC offers the navigation program in these 9 Maine counties: Somerset, Kennebec, Lincoln, Oxford, Androscoggin, Knox, Saginaw, Franklin, and Waldo. Okay, let's begin with discussing demographics within the state of Maine and the Youth and Family Navigation Program. So here we have some general youth-centered statistics regarding Maine youth. Suicide is the 2nd leading cause of death among Maine youth aged 10 to 24. Maine ranks number 1 in the country for anxiety amongst adolescents. And lastly, Maine has the 3rd highest rate of depression amongst youth nationwide. When the Maine Integrated Youth Health Survey evaluated Maine high school youth in 2019, the data reflected imminent need for low-barrier programs to address suicidal ideation and suicide-related behaviors. Topics related to mental health, Mayans found that across the board, numbers had increased significantly from 2017 to 2019. They found 32.1% of adolescents reported feeling sad or hopeless, resulting in a 5.5% increase since 2017. Additionally, 16.4% reported seriously considering suicide, resulting in 1.7% increase since 2017. And finally, the survey shows that 8.9% of adolescents reported attempting suicide at least once, thus making it a 1.5% increase since 2017. When analyzing crisis and counseling data regarding adolescents in crisis during the 2021 to 2022 fiscal year within Kennebec and Somerset counties, we found a total of 725 adolescents between the ages of 10 to 24 received crisis assessments. Of that 725, 38% accepted internal referrals to aftercare services. 75.4% of those assessments completed were the adolescent's first initial crisis. And lastly, we found 24.6% of those accounted for crisis assessments were adolescents who represented for additional assessments. The following data regarding demographics were captured during an early analysis of effective treatment within our youth and family navigation program. We found 38.3% of clients who engaged in services fell between our 10 to 14 age bracket, 48.9% fell between our 15 to 18 age bracket, and lastly, 12.8% fell between the 19 to 24 age bracket. All right, so let's take a peek at the client demographics as it relates to gender or gender identity. We found 61% of clients who engage in services identified as cis female, 1.25 identified as trans female, 13.8 identified as non-binary or gender non-conforming, 21% identified as cis male, and 2.8 identified as trans male. During our county analysis of clients who resided in our catchment area during the duration of the program engagement, we found 65.6% of our clients resided in Kennebec County, 20.9% in Somerset, 4.4% in Oxford, and the other counties collectively represented 9.1% of youth engagement. Please note, both Hancock and York fall out of our youth and family navigation catchment area, but these clients still receive services. So here we have initial lethality scores captured upon intake of all clients. We found that 20.8% fell within our low percentile, 40.7% fell within our moderate percentile, and finally 37.6% of our clients fell within our severe percentile. Our final demographic I'll be discussing today is the screening factor captured upon intake. 98% of our adolescents presented with multiple symptoms and stressors. Our highest reported symptom is suicidal thoughts. We found 97.1% of all clients reported experiencing suicidal thoughts. 87.6% reported experiencing depression and anxiety. 59.8% reported experiencing self-interest behaviors. 50% reported experiencing home life stressors. 42.8% reported experiencing anger and impulse control. 40% reported struggling with bullying and interpersonal relationships. 39.2% reported experiencing school stressors. And lastly, 20% reported engaging in substance use or risky behaviors. Within the framework section of this presentation, I will discuss the primary prevention measures and review the unique three-tiered phasing structure that was created to increase the capacity of our one full-time physician within the Youth and Family Navigation Program. Before I begin, it is imperative we discuss the value of upstream prevention and intervention for suicidal ideation and suicide-related behaviors within adolescents. Many studies, including the ones utilized within this slide, all discuss the varying benefits and successes in implementing upstream prevention and intervention for decreasing suicidal ideation and suicide-related behaviors amongst adolescents. The data points include findings from 105 corresponding articles to 99 unique studies that address the following. 1, effectiveness of upstream suicide prevention and intervention amongst adolescents reporting suicidal ideation and suicide-related behaviors. 2, the effectiveness of 4 unique therapeutic modalities as it relates to decreasing suicidal ideation and suicide-related behaviors amongst adolescents. While efficiency rates vary across all 4 modalities, all were proven to yield similar results. For instance, when we take a peek at our CBT-based intervention we utilized, the studies found 40% decrease in suicide-related behaviors as 60% decrease in suicide-related behaviors. When a DBT-based intervention was utilized, these studies found there was an 83.3% decrease in suicide-related behaviors and a 66.7% decrease in suicidal ideation. When a family-based intervention was utilized, these studies found there was a 44.6% decrease in suicidal ideation and a 33.3% decrease in suicidal attempts. Lastly, these studies found when a crisis intervention-based program was utilized, there was a 65% decrease in suicidal ideation and a 40% decrease in suicidal attempts. We're going to start reviewing the system structures within each phase. So for instance, our phase 1 in our youth and family navigation program. In this phase, youth and caregivers are expected to engage in 4 direct service hours per month. Phase 1 of the program begins after intake is complete. The navigator will create a unique treatment plan based on lethality scores, safety concerns, identified goals reported by the adolescent and the families. Unique safety plans will be created in collaboration with the youth, caregivers, and providers. Navigators create unique curriculum and combine therapeutic modalities such as CBT, DBT, ACT, IPT, and family-based interventions to support youth and family as they work towards their personal growth. The navigator will provide ongoing safety planning, counseling on access to lethal means, lock boxes and gun locks will be issued on an as-needed basis at no cost to the adolescent and caregivers. Lastly, education and connection to mental health resources will continue to be provided. The structures within phase 2 of the Youth and Family Navigation Program. In this phase, youth and caregivers successfully navigate activating stressors and are expected to engage in 2 direct service hours per month. In phase 2 of the program, navigators will review the current safety plans with adolescents and caregivers to determine if all areas of concern are current and counteracting coping skills are effective. Another counseling on access to lethal means will be conducted. Navigators offer a unique approach to low barrier family services. Therefore, any adolescents and families engaged in services will be offered referrals to any identified supports or a number of potential services. These include primary care physicians, therapists, care managers, med managers, and more. During this phase of our program, adolescents are successfully able to utilize emotional identification to implement distress tolerance and coping skills as needed. Adolescents and caregivers have successfully and safely navigated activating events with communication, transparency, advocacy regarding mental health symptoms, and continued safety concerns. The system structures within phase 3 of the Youth and Family Navigation Program. In this phase, adolescents and caregivers are frequently able to navigate activating events and are expected to engage in 1 direct service hour per month. In phase 3 of the program, adolescents regularly maintain baseline behaviors, low lethality scores, and safety concerns. Adolescents and their caregivers are frequently able to either navigate activating situations successfully or utilize skills to intervene and prevent activations and crises from occurring. The youth will sustain well-being and safety with use of communication. If referred while in the program, adolescents will begin to attend appointments with their long-term provider on a regular basis. Navigators will review and revise a final safety plan with the adolescent and caregivers and complete 1 final counseling on access to lethal means and preparation for discharge. Here we have a table that reviews the analysis of primary prevention measures in practice as it pertains to each phase in percentile data. Adolescents are ready to graduate phase 1 and enter phase 2 after having successfully decreased lethality scores, begin to identify and establish an understanding of personal activators, successfully navigate activating events, and utilize safety planning and coping skills and natural supports to assure safety. At this time, adolescents will have successfully completed 1/3 of their personalized treatment plan. Adolescents are ready to graduate from phase 2 and enter phase 3 after having decreased lethality scores, maintaining baseline behaviors, regularly utilizing distress tolerance and coping skills to navigate stressors successfully. At this time, the adolescents have successfully completed 2/3 of their personalized treatment plan. Adolescents are ready to graduate from the program after having maintained a low to no lethality, maintaining safety, integrating services with long-term providers, and completing their personalized treatment plan. At this stage, adolescents have successfully and fully integrated into the community. Next, we will review the current outcomes and analysis of the Youth and Family Navigation Program so that we may gain insight of the impact the program has had within the past 2 years. Please note, all data reflects the work of one full-time position that was provided through funding through the GLAS grant during the duration of the program. The following data was captured during an early analysis of effective treatment and services provided to each adolescent and their caregivers within our Youth and Family Navigation Program. From the start of the Youth and Family Navigation Program in fall of 2020 to now, navigators were able to provide direct care services to 322 youth and families. We've been able to complete 1,350 direct service hours where a mental health screening was completed. We've provided 395 safety plans, 345 counseling on access to lethal means, and we've been able to distribute 85 gun locks and 70 lock boxes at no cost to our youth and their caregivers. During the same analysis review, we found the current average length of engagement within the program was 22 weeks. We found 86.5% of adolescents fulfilled graduation criteria, all with low lethality scores and connection to long-term providers. In addition, we found only 5.95% of adolescents had re-entered crisis within the past 2 years after graduating the Youth and Family Navigation Program. It is important for us to note when reviewing our Youth and Family Navigation Program success rate and long-term stabilization, we were only able to access 87% of our graduated Youth and Family Navigation clients' long-term profiles in our crisis catchment area, thus making a potential 13% margin of error regarding success rates. Data markers show if all graduated adolescents that fall within a small margin of error were to re-enter crisis, our success rate in long-term stabilization of suicidal ideation or suicide-related behaviors would decrease from 94% to 83%. Next, we will discuss our hopes for the Youth and Family Navigation Program at Crisis and Counseling Centers. Our next steps: integrating and expanding the system structure to ensure internal growth so that we may increase the number of navigators, as well as increase the capacity, availability, and community relationships and collaboration with other providers and agencies across all 9 counties. As we begin, we want to start implementing the outpatient style therapeutic groups that will increase the variety of low barrier programs available. To meet the needs of clients within our 9-county catchment area, I was able to construct an outpatient style therapeutic group for adolescent and caregivers, thus creating a new level of care addressing the need for low barrier preventative services. These groups were piloted over the spring and summer of 2022 within our Adolescent Crisis Stabilization Unit. Each group was found to be effective within each unique structural dynamic. The first group to be piloted was our Creative Expressions group. This group utilizes art-based activities, character education curriculum to explore a variety of topics that impact interpersonal relationships, academics, the adolescent well-being, and sense of self. Next, our adolescent support group provides a supportive, non-judgmental environment where members learn how to boost self-confidence, strengthen interpersonal relationship, and cope effectively with daily stressors. Lastly, our Fostering Connections group explores a variety of topics that impact interpersonal relationships while focusing on growing communication, transparency, and mental health advocacy between a youth and a caregiver. So just to kind of wrap things up from what we've discussed today, we know that suicide is the second leading cause of death among Maine youth aged 10 to 24. To combat high suicide rates among adolescents with long wait lists for clinical services, the Youth and Family Navigation Program was created. Launching in 2020 at Crisis and Counseling Centers, navigators have served 322 youth and caregivers and made 1,350 contacts with an adolescent or family where a mental health screening was conducted. These numbers are ever growing as navigators widen our reach to make connections with agencies, schools, and most importantly, Maine adolescents and their caregivers. An early analysis of Kennebec and Somerset counties indicate a 94% of our graduated adolescents have yet to re-enter crisis within the past 2 years at CNC. Thank you for being present for the presentation. As always, please drop any questions in the chat box below. I'm going to leave up our contact information because one of the things that I didn't state was how we may get referrals. So for instance, we receive internal and external referrals. So if, for instance, you are a caregiver or somebody who has a youth in your life that might be referred to the program, you could reach out to our open access line and you'd be directly connected with somebody who would be able to get you connected to our youth and family navigation program.
Thank you so much, Kay. That was I learned a lot from your presentation, and it's so impressive the work that you've been doing with youth. So thank you so much for that. There are a couple questions that have come in, and I encourage folks that if you do have other questions to use the Q&A feature in the conference platform. The first question is, can you talk more about the benefit of flexible grant funding and how that has enabled you to be most impactful?
Yeah, one of the biggest things is that we are a grant funded program. Many times caregivers run across barriers as it relates to insurances. There's a long wait list for specific clinicians or providers that have only certain insurances that they follow. In addition, main care, for instance, depending on what services you are currently being provided, there are some barriers for accessing additional services. So we're able to offer a service at no cost to our clients, thus kind of taking down any financial barriers in place or barriers related to insurance purposes. Additionally, I know that our crisis and counseling centers, we were able to structure our program specifically for the unique needs of our clients within our catchment area. And because of the grant funding, we've been able to utilize that in kind of any way that we know would fit our program. I do know that our sister agencies do the same thing. So just being able to structure a program uniquely to the catchment areas has been increasingly beneficial. And we've been able to do that because of the flexible grant funding.
That's really, that's, I was gonna say special, but very fortunate. That's great because it sounds like it enables you to have even more tailored programming to meet the needs of the youth that you're serving. So that's great. The next question that I see here is around the data on the gun locks, and just noting how impressive that was. And can you talk a bit more about what those conversations looked like in order to implement those?
Yeah, so I am super happy to have this really phenomenal relationship with our main CDC representatives. They were able to find funding that could be allocated to free medlock boxes, as well as make connections with the VA for gun locks. So by having those really great connections with different agencies within our catchment area, we've been able to provide ongoing free gun locks and medlock boxes to any adolescents and families who reported them of need. Additionally, upon intake now, since we've been able to provide them so frequently, each adolescent and family will walk away with at least one medlock box and at least one gun lock. Depending on the certain situation, we will provide more than one gun lock, so that if, for instance, they have a family member that they go visit, they can not only bring the medlock box with them, as well as provide different family members a gun lock so that we assure safety at all times.
Great, thank you. There is one more question, a new one. There is such high representation from trans and gender diverse youth. How do you navigate supporting them in unsupportive family contexts that might be a push factor towards suicidal ideation?
Yeah, so yes, we have a large population, which we're very proud to be able to represent and assist. And because of that, there's been a lot of background work as navigators to find so many connections. So for instance, ongoing connections with the Trevor Project, as well as Maine Transnet, we've been working with them as well, and we constantly kind of refer adolescents. We talk with them about the family structure. If it's not safe at home, what can we do? So a lot of our safety planning is maybe tailored around a unsupportive home environment. We're doing constant check-ins with whether we feel safe, what names and pronouns it's for us to utilize when we're talking about a family structure, as well as it's important for us when we get them connected with a long-term provider. That long-term provider is going to be supportive and affirming of their gender identity.
Great. Thank you, Kay. Yeah.
Yeah, so I was also going to say one of the biggest impacts that we have when we start talking with our adolescent and their family is the personal conversation we try to start having with their caregiver, where it refers with leading with kindness. Though you may not understand what's going on, in some ways you don't have to. You can still lead with kindness and understanding and support of your adolescent because their life matters. And so we want to cultivate a space where maybe there is not that understanding that you have, but there's still that kindness that is the most important factor.
Yeah, I love that. And that I think is a good concluding perspective for your presentation. Thank you so much, Kay, for this. And I want to thank everybody who joined today's session. Thank you to Kay for the incredible work that you are doing. And I just want to remind folks to please complete the session evaluation. We're going to take a short 10-minute break as we transition to our next session, which is called Digging Deeper, Growing Farm to Early Child Care and Education Participation in Maine. So we'll see you back here at 2:50. Thank you.